title is Oxygen Exposure Quantified by Time-Weighted Area Under Curve for Arterial Oxygen Content is associated with mortality in mechanically ventilated patients. Over to you.
Thanks. So this project was undertaken with Mahesh Ramanan, one of the intensivists in Brisbane and PhD candidate at the George Institute. And our project was on the relationship between arterial oxygen content and mortality in ventilated ICU patients. So by way of background, oxygen therapy, as we know, is frequently administered to ICU patients, both to treat and prevent hypoxemia, and the harms of hypoxemia are very well known. But the risks associated with supranormal oxygen levels in critically ill patients are much less clear. And recently, there's been a growing body of evidence to suggest that high oxygen exposure can cause harm. And there are a number of possible mechanisms by which this could occur. So what we know is that at a cellular level, direct toxicity of hyperoxia leads to histopathological changes similar to those seen in ARDS or with ventilator-associated lung injuries. And we also know that hypoxemia, it may impair the innate immune response, reduce mucociliary clearance, and result in the production of reactive oxygen species. But despite these apparent risks, we also know that ICU patients are still subjected to substantive periods of hyperoxia, and it mostly seems to occur at a low FiO2. And the effects of oxygen therapy are usually measured via arterial oxygen saturation, partial pressures, or O2 sats. And normal values vary with age and with chronic respiratory conditions, and specific PaO2 and SaO2 targets don't really exist. So rather than investigate these values, we looked at arterial oxygen content, or CaO2, and the arterial oxygen content, just to refresh, is the total amount of oxygen carried by blood, so both dissolved in plasma and bound to hemoglobin. And it can be given by this formula here, where that number on the end there, see if this works, is the coefficient of oxygen solubility in plasma. So it makes sense then that as the solubility of oxygen in the blood is low, CaO2 is largely determined by the hemoglobin concentration and the percentage the hemoglobin is saturated with oxygen. So when hemoglobin is fully saturated, additional oxygen only will marginally increase that CaO2. And arterial oxygen content might be a better indicator of oxygen delivery to tissues, but there's no evidence to support that currently. And despite the availability of the components to derive the arterial oxygen content, it isn't routinely calculated in clinical practice. So our goal was to determine whether oxygen exposure over an entire ICU admission, as determined by time-weighted CaO2, is associated with mortality in ventilated patients. So we used the MIMIC3 database, which is an open access research database. It includes all patients admitted to medical or surgical ICUs at the Beth Israel Deaconess Medical Center in Boston, Massachusetts. The database contains 46,000 individual patients over an 11-year period. And our inclusion criteria is here. So first ICU admission for patients 16 years or older who were intubated and mechanically ventilated at some point during their stay. We excluded patients who had 2 or fewer ABGs or where the data was incomplete and there wasn't a recent hemoglobin that we needed to calculate the CaO2. And data was then extracted for age, sex, admission type, so whether they were elective or emergency admissions, illness severity, which we used a SAPS-2 score, as well as a comorbidity score, and as well as whether patients were transfused or not. And we also extracted hospital length of stay, ICU length of stay, and duration of ventilation. So our primary outcome was mortality at 6 months, and this is the study recruitment diagram to the left here that shows of the 46,000 eligible patients, we were left with 7,450 that met the inclusion criteria. So by way of analysis, CaO2 was calculated for each ABG using that formula I just showed. And then the time-weighted area under the curve for CaO2 was calculated using a trapezoidal method for each patient using all ABGs over an ICU stay. And the same method was used to calculate the time-weighted FiO2 as well. Multivariate logistic regression analysis was then performed to determine the effect of CaO2 on mortality after adjusting for confounders. So the overall 6-month mortality rate was 26%, and as you'd expect, there are a number of variables associated with significantly increased odds ratio of mortality. So this table shows, it's a bit busy, but it just shows the differences between the baseline characteristics of survivors and non-survivors. So non-survivors, probably predictably, were older, were more likely to be transfused with packed red cells, and were much more likely to have an emergency rather than elective ICU admission. Non-survivors also had longer ICU length of stays, longer mechanical ventilation hours, longer hospital stays, a higher median SAPS-2 score, and higher comorbidity score. So in the univariate analysis, there was no relationship between mortality and arterial oxygen content. However, and this is probably the take-home point of the study, after we adjusted for age, sex, transfusion, admission type, comorbidities, and illness severity scores, and the time-weighted FiO2, a higher arterial oxygen content was significantly associated with increased mortality. So this slide shows the results of the multivariate analysis after adjustment. And arterial oxygen content's been broken into quartiles here, which are shown in bold at the top. So the highest quartile had an odds ratio of 1.22 compared with the lower quartile. And as you can see in the the lower part of the table, the other variables remained highly significant. So this slide really just shows the same results. The first one demonstrates the odd ratio of mortality by time-weighted arterial oxygen content, and the second graph the same after adjusting for all the variables that we've just mentioned. So this is the first study to investigate the relationship between CaO2 and mortality, and it's the first to do so in a critically ill population. Another potential strength is that the MIMIC-3 data that we used it's been used extensively for research purposes, and the inclusion of all ABGs over the duration of an admission is probably an advantage over some previous research which have relied on best or worst or highest or lowest PaO2 levels, or only on static values within the first 24 hours. However, despite a relatively large number of patients, we weren't able to establish a lower threshold below which hypoxemia was associated with increased mortality. So we found that in mechanically ventilated ICU patients, after adjusting for illness severity and comorbidities, higher oxygen content as quantified by time-weighted, or higher oxygen exposure quantified by time-weighted CaO2 was associated with increased mortality. But the relationship between arterial oxygen content and mortality in our study was non-linear, with the association between mortality and CaO2 most pronounced at a high CaO2. And there are a number of possible explanations for that. So firstly, it's possible that the harm associated with hyperoxia, if that's what's happening, might occur only at high levels of exposure, and that's at least partially supported in some animal models. But the second possibility is that the higher CaO2 levels might also reflect a higher presumed clinical risk, acting as another marker of illness severity, with supplemental oxygen provided as a bit of a safety net to patients of presumed higher risk. So to sum up, this data provides some further evidence to support this growing body of literature that suggests harm associated with hyperoxia. Oxygen exposure as a second point over an entire ICU admission and an entire hospital admission is an important consideration. And then finally, we suggest that CaO2 is another important consideration, and it might be of benefit to clinicians in addition to just PaO2, SaO2 or SATs. Thanks.
Thank you, James. On to the questions. Jeff.
Yeah, great work. I just have a physiology, a question to ask you. Your CaO2 is largely dependent on your hemoglobin, and given that we gate our saturations at the clinical level, now you will usually be between about 90 and 95. The variance is going to be small, plus the amount of dissolved oxygen is also small.
Yep.
So isn't your study, give or take, just a study that associates hemoglobin level with outcome? Because your CaO2, essentially 90% of it is actually determined by your hemoglobin.
Yeah, that's a good point. We didn't actually, in this study, look at the effect of hemoglobin by itself, but that's probably the next step to sort of see what the relationship between those is.
Can I ask a follow-up question?
Yeah, absolutely.
Toxicity, in my view, is due to oxygen tension, because that will reflect the transfer of oxygen into the tissues rather than content. So I'm talking about the biological plausibility. Would you like to comment on that? Why do you believe CaO2 is important and not oxygen tension per se?
That's a good question as well. I guess the current sort of metrics that we use at the moment, they're designed really to estimate what's happening at the tissue level, which we can't measure exactly. And we're wondering whether CaO2 might be a sort of another possible way to sort of estimate that. But I take your point there.
Okay. Yeah, can I just ask a question about the population? I didn't get a feel for who they were. Do you know what patient groups were dominant in that population?
So it's a single centre in Boston, but it's broken up into medical and surgical ICUs. It's in terms of, I think it's probably relatively reflective of the sort of patients that we would have in Australia. It is a big cardiothoracic centre, so there possibly might be more post-op patients included in this study. And then I think there's, of that 46,000, I think there's about 7,000 or 8,000 neonates that obviously were excluded straight away. But otherwise it's sort of it's quite a mixed centre.
Very, very quickly, I think the potential biggest issue with retrospective analyses like these that use multiple adjustments is the risk of unmeasured confounders. Can you comment on anything that you would have liked to have had that you couldn't adjust for? Yeah,
absolutely. So I think probably the weakness with our adjustment was the use of the SAPS-2 score, which, it was highly significant, but whether it provided enough sort of adjustment, it would be much better if we had access to Apache 4 or a better, predictor. So I think that's probably the main one. The other things that we didn't have access to, so we broke things down into whether patients were transfused or not, but we don't know sort of where in their ICU journey or how much they were transfused, or so that's sort of another drawback that we would obviously like to have more information on if we could have.
Thanks for that meticulous study. It's a vast amount of work. Like Jeff, I am a little bit uncomfortable about your conclusions. Your upper quartile, which was 14, greater than 14, 14.2, where you had the highest mortality, is still way less than normal. Yours, standing right there, is probably near 20, and I don't think that you have a mortality that is associated with that. So what you've got is a disconnect between your findings and normal physiology. So I suspect that Jeff is right, that the CaO2 is not in fact a driver. It's in fact you've got anemia and then the high driving pressures from PaO2.
Yeah. Yeah, the other possibility, of course, is that clinicians are just pushing oxygen on patients that they think are sort of higher risk. But no, I take your point, yeah.
Thanks very much. Another round of applause for James, please.